introductory a few introductory remarks. So welcome everyone, and thank you for joining us. We are very glad to have you here today. My name is Simona Barbu, and I'm a policy officer at FEANTSA, and together with my colleague, Raquel Carvalheiro, she will present herself shortly. We are your hosts today for this webinar on health inequalities and homelessness. And we are very glad to see that there is so much interest for it, and we welcome all of you for the next 1.5 hours. So first of all, just to remind everyone about a couple of practicalities on how we will conduct the webinar today. You may have noticed that we are in a meeting mode, so that means that we will be able to see each other and to hear each other. So please make sure that you mute yourselves during the presentations made by our speakers. And also, as you have seen, we are recording the webinars, and so if you don't want to appear on the video, you can keep your camera off and remain in listening mode. Thank you for that. That being said, I would also like to encourage all of you to share with us where you are joining from and what are your experiences with working on the right to health for people facing homelessness. So you can do that in the chat and also write any questions that you may have for us today. And we will also have time for discussion at the end. After all presentations have been made, you can raise your hand and take the floor. So today's webinar on health inequalities and homelessness is part of a 3-webinar series, which we at FEANTSA dedicated to perhaps one of the most pressing social challenges, that is the deep connection between homelessness and disparities in health outcomes. And while today we will take a more general approach on health inequalities, we do have 2 other webinars which will focus on more specific issues. Respectively, the second webinar will approach the topic on homelessness and tuberculosis, and the third and last webinar will discuss homelessness and mental health. So if you are interested to join us for the other 2 events, we will paste a link for registration in the chat as well. And maybe a last remark from my side is to say that this webinar series is part of our work at FEANTSA to raise awareness on the health inequalities that people experiencing homelessness face, and to promote a better understanding of health needs and barriers which prevent marginalized people to access health services. So about this work, briefly, I would add that our members across Europe, they facilitate access to health services for people on the ground. And from here, the secretariat that we have in Brussels, we also work to follow any public health policies at EU level and to ensure that the needs of those experiencing homelessness are taken into consideration. So today you will have the chance to listen to a couple of our members and partners directly, and for questions on EU policies, we also remain available. That was it from me, and without any other delay, I will pass it on to Raquel to introduce herself and the program for today. And again, thank you for joining.
Thank you, Simona. Hello, everyone. My name is Raquel Carvalheiro. I'm the Health Policy Assistant, and thank you so much for joining us today. We are excited to have you here, and I hope this webinar will provide us a meaningful discussion on the intersection of health and homelessness. Today, we will be exploring how people experiencing homelessness often face significant barriers in accessing health services, which exacerbates health inequalities and worsens health outcomes. As for our program, first we will be hear from Tobias Fragner from the Medical University of Vienna Center of Public Health. He will share the key insights from his research on the barriers and facilitators to healthcare access for people experiencing homelessness across 4 European countries. Following his presentation, we will explore some challenges, but also to see how we can overcome these barriers with 3 presentations from fieldwork organizations that are actively working on the ground. And actually, it will be 2 presentations since one of our speakers from Portugal, Crescer, won't join us, unfortunately. So first, we will be listening from Pierre Rickmans from Infirmières de Rue from Belgium, and then from Hungary, we will listen, Istvan Dande will present from the Budapest Methodological Center of Social Policy and its institutions. And then in the end, we will have the Q&A session that we will open the floor for all the questions and that you might have. So, Tobias, maybe you can start whenever
Right,
you.
perfect. Thank you very much, Raquel and Simona, for the very nice introduction. Let me just quickly share my presentation with you. Okay, could you just confirm that you see it? Okay, perfect. So hello, everybody. Welcome and good morning also from my end. I'm really happy to have the opportunity to introduce this very important topic to all of you today. So the title of my presentation here, as you can see, is about barriers and facilitators to healthcare access for people experiencing homelessness in 4 European countries. Yeah, as Raquel said, my name is Tobias Wagner. I work at the Medical University of Vienna in the Department of Social Preventive Medicine of the Center for Public Health. And what I'm going to present to you today are the findings from a study that we conducted within the framework of a larger scale project, which was called Cancerless. So Cancerless has been funded by the European Union's Horizon 2020 program and was focusing on cancer prevention and early detection among people experiencing homelessness in Europe. Within this project, we have been co-adapting and implementing a novel healthcare model that is also focusing on cancer prevention. It's called the Health Navigator model, and I will talk about that in more detail later. So first of all, I just want to point out who has been collaborating within the study. It's also important to know where the study has been conducted, also in order to get a better understanding of the findings, probably. So this study has been, or this project was actually a collaborative effort by 11 organizations all around Europe. So in total, 6 countries, organizations from 6 countries have been participating here and contributing substantially to the success of the program. The leading organization of the Cancerless project was the Medical University of Vienna. So this was that the principal investigator of the project and project coordinator was Professor Igor Grabovac. And I have been part of his team, of this coordination team throughout this project. What is very unique and special about this consortium is that we have been collaborating with institutions that were both academic and non-academic.
Sorry.
Okay, sorry, I was muted. So organizations, both academic and non-academic. So we have been working with academic organizations that have been responsible for the research activities and the methodological rigor within the project, but also non-academic organizations like NGOs who were actually providing healthcare or who are providing healthcare to underserved populations, also including people experiencing homelessness. So I think this has been a very unique approach to this project. So I want to talk a bit more about the background. So as I said, Cancerless was focusing on cancer prevention in people experiencing homelessness. And before we come to that in a bit more detail, I want to point out why it is actually important to take into consideration the intersection of homelessness and health. We do know that homelessness is linked to premature mortality. People experiencing homelessness do experience an average life expectancy of 47 years, which is actually about 30 years lower compared to the housed population. So this is, of course, a very dramatic discrepancy between life expectancies. There are numerous reasons why people experiencing homelessness do face this premature mortality. Among the most prevalent causes are violent causes and trauma, but also, of course, mortality has a seasonal distribution. It is higher in winter when people are more struggling outside, if they can't find accommodation, if they can't find a safe space to sleep. Of course, this is also a contributing factor to higher mortality and a seasonal matter. Next to the violent causes and trauma, the second leading cause of death among people experiencing homelessness is cancer. So this has been the reason why we wanted to raise awareness for cancer and cancer prevention. And also because cancer prevention is something that is very comprehensive and holistic. So cancer prevention is not just cancer prevention, but it's also, of course, something that has an effect on the prevention of other diseases as well, and other factors. So there are a lot of disparities that people experiencing homelessness face when it comes to accessing healthcare services. We could actually separate these barriers into different levels, but I think what is very important in this regard are the systemic barriers that people experiencing homelessness face when they want to access healthcare services. So especially regarding primary and secondary prevention or community health services, people experiencing homelessness have a lot of trouble. This is mainly due to factors like stigmatization, because they have experienced trauma when they try to access healthcare services. They don't feel comfortable with the service. Maybe they also do not have the insurance they would need to in order to access these services. So all of these factors and a lot more, of course, do contribute to or do lead to people experiencing homelessness utilizing services that are mostly within the acute healthcare settings. So when this is mostly when a disease has already progressed to a stage where it is very difficult and hard to treat it. So due to these barriers, so especially the systemic barriers, contribute to treatable medical conditions causing premature mortality among people experiencing homelessness. And this, of course, also includes cancer. So as I said, cancer is the second leading cause of death among this community. So it is very important to also take this into consideration. From research studies, we know that these systemic barriers could be addressed through early and effective healthcare services that are individualized and tailored to the needs of people experiencing homelessness. And as of now, we just do not have enough of these tailored services. So what have been the concrete research questions that we have been asking within this study? So we wanted to know what are the barriers that people experiencing homelessness face when they need to access general healthcare services. But also we wanted to know what factors do facilitate access to these healthcare services, so that we could have a better picture that showed us what prevents them from going to the services and what supports them in going there. So in order to find this out, we decided to conduct an exploratory cross-national qualitative data collection. that happened from August to October 2021. And it was a cross-national study because we conducted this simultaneously in 4 European countries, namely Austria, Greece, Spain, and the United Kingdom. In total, we have conducted 69 semi-structured interviews throughout these 4 countries, 69 people participating in this qualitative study, where 35 of them were people experiencing homelessness, and the other participants were actually professionals, 15 of them working in homelessness support services, and 19 of them were health professionals that did not necessarily work explicitly with people experiencing homelessness, but of course they also have in some way contact to this community. So this were, for example, primary care physicians, nurses, oncologists, psychiatrists, and of course other health occupations. For this study, we decided to conduct an inductive thematic analysis according to Saldana. This inductive approach basically means that we did not have a predetermined framework that we used to analyze data, but we actually wanted to let the data speak for itself, basically. So from the interviews we conducted and transcribed, we derived codes that were then grouped into categories, and also then these categories were grouped into themes. And based on this approach, we have identified 3 themes within our data that were overarching our findings. So theme 1 was the healthcare needs of people experiencing homelessness, where participants told us about what do people actually need in terms of healthcare. Another theme was about barriers to healthcare access, and the third theme, facilitators to healthcare access. And I want to go into more detail here now. So regarding the healthcare needs of people experiencing homelessness, we found that there is a very high or disproportionately high prevalence of mental health conditions and chronic illnesses. Also, the living conditions of people experiencing homelessness directly impact their physical and mental health. And the impact of homelessness on health is pronounced for those with pre-existing health conditions. And in my opinion, it is very important to actually have this in mind when we are talking about homelessness and health, that these are 2 very interconnected factors that are influencing each other. So we cannot always say that hardly ever say that the homelessness occurred because of the diminished or of the poor mental or physical health of a person. But of course, it can also go the other way, the other direction, that the homelessness has been contributing to poorer health outcomes. So this is always very important to have in mind, that this is a very complex interconnection and should be taken into consideration when we want to provide people experiencing homelessness with healthcare services. What is very important and was also found in our studies, that people experiencing homelessness are an extremely heterogeneous population with differing health profiles. So there is not this one stereotypical person experiencing homelessness, like it is always depicted in media, for example, the old man with the long beard living on the streets. So it's a very heterogeneous population that is not always affected by rooflessness, but maybe also sleeping with family, staying at families or friends' places. And of course, these different living situations and conditions affect their health in different ways, or affect what they need in terms of health in different ways. This is, of course, also something that is very challenging for health and social care professionals, that there is not this one person experiencing homelessness, but that we have to actually think about a lot of other aspects when we are dealing with a person who is experiencing homelessness. And for this theme, I want to show a very good quote that has been said by one of our participants in Austria, who was also experiencing homelessness. And this person said that absolutely homelessness does have an impact on health, not only on mental health, but also physical health, because people are constantly moving, whether it's cold, warm, or sub-zero, they're constantly outside. And of course, that affects the body. When something hurts, many people solve it with alcohol. So this quote, I think, really depicts well how complex the issue of homelessness and health is. And also it refers to this seasonally higher mortality among people experiencing homelessness. Regarding the second theme, which are the barriers to healthcare access. So this is what we actually found as concrete barriers to healthcare access, is that poor physical and mental health in itself are barriers to accessing healthcare. Also, addressing health needs is generally not treated as a priority among people experiencing homelessness, but this statement has to be considered very carefully, because it does not mean that health is not important to people experiencing homelessness. But of course, it can't always be treated as a priority, because there are mostly some other issues that people experiencing homelessness have to take care of first before they proactively want to improve their health, because they need to make sure that they have enough food, that they have clothing when it's cold, that they find accommodation for the night. So yeah, it is very important. It's not generally a priority, but it is something very important and something that matters. Compared to people not experiencing homelessness, people experiencing homelessness encounter stigmatizing and judgmental attitudes from healthcare professionals in public settings. This is something that is very consistent with the body of research so far. Also, what has been found in other studies, that people experiencing homelessness are mostly encountered with stigmatizing behaviors, and therefore try to avoid accessing healthcare services. Which is then in turn leading to them only going to services within acute healthcare settings. Also, of course, inflexible and fragmented healthcare systems thwart timely access for people experiencing homelessness. So healthcare systems are not, or especially in those 4 countries that have been, where this study has been conducted, the healthcare systems are very fragmented. They're not connected with each other. And this makes it, of course, very complex for people experiencing homelessness to follow a certain healthcare pathway. People experiencing homelessness also face bureaucratic barriers, such as not having a fixed address. This is, of course, a very practical issue, because they can, for example, not receive letters from a hospital or another healthcare service. Sometimes, or in specific settings, people are not administered if they do not have a fixed address and things like that. They do not get health insurance if they don't have a fixed address. So this comes with many other issues again. So also here I want to show you a short quote from one of our participants from Spain. The priorities of a person living in a house can be taking care of themselves, going to the doctor, and so on. But when you are living on the street, your priority is to eat something and not have your belongings stolen. And this is something, again, referring to the issue of priorities. Health can most of the time not be a priority as long as there are more basic needs that are not addressed. Regarding the third and last theme of this study, the facilitators to healthcare access, we found that a very great facilitator is a positive relationship between a person experiencing homelessness and healthcare professionals. Because of this is something that encourages them to attend a specific service. Also, what we found is that it is important to adopt tailored and person-centered approaches when it comes to healthcare delivery for people experiencing homelessness. These services need to be responsive to the actual needs of this population. So when they are actually addressing the needs of what people experiencing homelessness need, they may be more supporting their access to healthcare. Also, what we found is that it is not that it is most successful when people experiencing homelessness are engaged to actually go to a social care or healthcare service, especially when it is mediated by professionals who are working in these settings, because they have an understanding of this community's needs. And they also may work in settings familiar to people experiencing homelessness. So of course, people working in a daycare center, for example, do have a better understanding of the situations and conditions that people experiencing homelessness face. And also here I want to share a quote from a nurse in the United Kingdom who said, "When I talk to drug and alcohol users, I always use the street terminology. And I dress like this for a reason. I think uniforms are a barrier. If I'm wearing a uniform, people won't engage." And this is a very, very important information that this nurse obviously knows how to better approach people experiencing homelessness. And therefore she can use this knowledge to improve or to approach them better. Okay, and regarding the conclusions of this study, we can say that there is a pressing need for more interventions that are aimed at preventing the factors that lead to homelessness, because of course, when homelessness is prevented in the first place, this is something that has a positive effect on people's health. Also, there's a need for more immediate responses in terms of the provision of secure accommodation. People do need secure accommodation so that this priority is addressed, and then they can better take care of their own health. And this in turn again empowers them to actually contribute or to improve their health. There is additional training and resources needed for frontline healthcare professionals. So their understanding of the health needs of people experiencing homelessness needs to be improved. People experiencing homelessness themselves would also need specific training and resources that empowers them through health literacy and through the improvement of the level of self-care. And also, a conclusion of this study is that any communication around cancer should be delivered using accessible and plain language, and also with translations available if necessary. Also speaking from a more transcultural level, it is very important that there are suitable translations available if this is needed. At local levels, focus must be placed on building relationships with and between health and social care providers, because this is something that we found very often within the studies, that the health and social care providers themselves are often not connected with each other. So building these relationships would allow for a more coordinated care pathway to be implemented. Also, of course, collaboration between these providers and the creation of multidisciplinary teams could also could contribute to better healthcare access. And also, of course, strategies for incentivizing involvement may be required, so that health and social care providers are more willing to actually learn something new about this neglected population. Last but not least, there is a need to address the social stigma that surrounds homelessness, especially when involving mainstream healthcare providers in program delivery, because this social stigma is, of course, something that often prevents people experiencing homelessness from going to specific places. So it would also need, it's also important to provide education to professionals about lifestyles and needs of people experiencing homelessness, so that they actually get a better understanding of this community's needs. And when they get a better understanding of this, this will also contribute to counteract this social stigma. And with this, I just want to say a few words regarding Cancerless, because our Cancerless project has been based on the findings of this study. And what we did within Cancerless was to combine two established healthcare models, the patient navigator model and the patient empowerment model. So these two models are very focusing on being community-based. They try to better provide people with services, to access promotion to services and remove barriers, but also to give people control of action and foster decision-making processes, foster health literacy and higher engagement. So we combined within Cancerless these two models and try to co-design what we call the Health Navigator model. So the Health Navigator model consists of components from both of these models, and it has been co-designed through the voices of people experiencing homelessness and also professionals working with this population. So we would have the most efficient...
I'm sorry, just to let you know, 2 more minutes and then...
All right, perfect. I will finish soon.
Thank you.
So through this co-design process, we developed or co-developed the Health Navigator model. And this is what the Health Navigator model basically looks like. It is a longitudinal, person-centered and community-based intervention that increases participation in both primary and secondary cancer prevention services and aims to reduce wider barriers to healthcare services. And it does so by implementing so-called health navigators in healthcare settings. So health navigator would be somebody with a medical or social care background who has knowledge of people experiencing homelessness needs. And these health navigators are trained to identify the health needs and barriers of their clients. They are trained to promote cancer awareness and self-management among their clients. They are trained to offer practical assistance, for example, in terms of taking care of paperwork together with their clients. And also they are trained to coordinate access to care so that people experiencing homelessness are not left alone with taking care of their own health, but they have somebody they can talk to who helps them and supports them in actually accessing cancer preventive care services. And with this, I want to end my presentation. If you are interested in the results of the Cancerless project, you can scan this QR code. We have defined on our result, based on our results, we have defined 7 policy recommendations that are also accessible through our website. And also the results of the study I've been presenting here can be accessed through this QR code. So thank you for your attention, and I'm happy to answer your questions later.
Thank you so much, Tobias, for your insightful and complete presentation. Now we will move on to our 2 presentations from fieldwork organizations. So now we will have Pierre Rickmans from Infirmiers de Rue from Belgium presenting. Pierre, whenever you want, you can start. Thank you.
Thank you, Raquel. Thank you for the invitation. We are very honored and pleased to be able to share our experience. First of all, Raquel, could you advise me when there are 3 minutes left? Because I used to speak a lot, so I need someone to tell me. And then with 3 minutes, I can wrap up and go to the conclusion. First of all, thank you very much, Tobias, for this very interesting and very clear presentation. And there were some elements I wanted to present also, but you did it very well. So it's great because you insisted on some topics I wanted also to insist. So there will be a repetition, but that's good because it's like that people learn it. There were some points that I have not thought about telling and who are important. And I didn't think about that because it's so natural for me. Stigma. If you have to avoid stigma, most of the time you have to go with the people. Not let them go alone in any administration or healthcare facility because it will not work, at least in the beginning. Tailored healthcare, that's very important to be, you face a person and you have to adapt all your doing and listening and speaking to this person and also the priorities you set. And then no uniform adequate language and so on. I cannot stress that more, and it was very good from Tobias to mention it because it's very important. That said, I will just present a little bit my organization and myself. I'm a medical doctor. I worked a time abroad with humanitarian organization. Then I came back in Belgium and started to work on social project with migrants and homeless people. And then 15 years ago, exclusively with homeless people with infirmiers de rue. Infirmiers de rue, it means street nurses. So in the beginning, we were an organization only with nurses and we went also only in the street. But with the experience, we learned that to bring healthcare to the people and to diminish their mortality, you have to do a lot more and with a lot more different professionals. So now, 18 years later, we are an organization with a medical doctor, with a psychologist, with social assistants, with educators, housing managers, and so on. And we don't do only medical care in the streets, and we do less and less proportionately, less and less medical care in the street, but we do it at home because we also have a part of our team doing follow-up at home of the people we rehouse. So, and I will explain why we made that shift relatively rapidly after starting our follow-ups. As you see, I have no PowerPoint because I thought you may have a little, relax a little bit and not always have a PowerPoint, which is sometimes a little bit, how do you say that, impressive, and you have a lot of information. I will give you 6 words that you should maybe remember, and then I will explain, of course, these words and how it works as a facilitator or as a barrier. And maybe there you will grab some things that interest you, but don't try to note everything because it's too much. And what is important is practical things that you want to try on the field and to use on the field. And that's maybe the difference between Tobias' presentation, my presentation. I will be much more on a practical level and try to give you tips to work on the field and based and coherent with what Tobias said on health and healthcare for homeless people. The first thing I want to say is that I will much more stress the aspect of health and maybe a little bit less the aspect of health care and access to healthcare, because, well, people die in the streets too early because of their living conditions, and a little bit less, I would say, because of their access or no access to healthcare. I have seen people in good health, apparently living in the street, having a good access to healthcare, going to their medical doctor and so on, and dying prematurely. And therefore, as a medical doctor, I changed my mind on the fact that maybe living conditions are much more important than healthcare. Well, you have to have a balance, of course, but that's a very important point. Speaking about healthcare, if or when you have the possibility to install it, you have to remember that you have to simplify. Keep it simple, at least certainly in the beginning, but it should be a general principle to keep it simple. So you have to have a good doctor that knows what it is to speak simply, to explain things, and also to have simple treatments. Do not complicate treatments. And yeah, sometimes you have to evaluate if it's reasonable to treat people that are still in the streets and which medication you could use in the streets. We don't use medication in the street because we think it's too dangerous. So we set up priorities to treat people once they are in a housing, and before that, okay, they have access to emergency, but for chronic treatment, it's dangerous because people or their treatment is stolen or they sell their treatment in the street, so it could be more dangerous. Keep it simple also administratively, and if necessary, do a lot of things administration for your patients. Moderate your ambitions and spread them in time. So not all, when you first go with the patient to a doctor, it's not reasonable to try to treat all the problems you see. So spread them on the time, and remember the most important thing is to create the trust so that the patient can come back to the doctor. And that's the most important thing. So don't try to treat all the things from the beginning, because you will just, your patient will be afraid and not come again. And so you have to make choices, and first thing first, but these choices have to be made with the patients. And knowing that the patient has his priorities, and maybe they are not the same as the doctor's priorities. And sometimes you have to accept to take a little bit more risk because the patient has another priority. So for example, we have been in a case where we have follow up the patient to make his teeth, to having teeth before rehousing him, because he didn't want to go to a home before having teeth. So we had to accept that. Even we knew he was taking risk by doing that. So sometimes you have to balance the priorities. So the first word for me is homelessness and also home. So homelessness is the biggest factor for bad health for the people, and home is the biggest facilitator for health and healthcare. So it's really, if you only remember one point, that's the key point. And it seems evident, but for me, for example, as a medical doctor, it was not. In the beginning, I thought housing was a social thing and not a medical thing. But now I'm completely convinced that housing is part of the treatment. And it's the biggest part in the beginning. So if you have people living in the street, the biggest part of the treatment is giving them a home. And why? A home with follow-up, because otherwise it doesn't help. And why do I think so? Because I have seen the results, and the result, you can see them on the long term. Long term, I mean several years. So you need, for people living a long time in the street, you need 1 or 2 years to stabilize them in the housing. And then after that, when they are stable, you can see the progress they make on mental health, on addiction, and other medical problem related. Why is that home is such a facilitator of health and healthcare? and why homelessness is such a danger. Because in a home you have the safety, so people can be there safe, which is not the case in the street, and which, like Tobias said, it's a factor of mortality, because you have aggressions and violent violent aggressions. Home is a place where you can sleep better. If any of us would sleep 4 hours a day and very bad sleep with stress, after a week you have hallucinations. Even even if you don't have a psychosis, you start to hallucinate because you didn't sleep enough. So good sleep is also a good factor of good health. You have access to food, better access to better food, and even after a while you can start to prepare some food. You can have help to have access to good food. You have direct access to hygiene. You have access to intimacy. You can be alone without trouble, without noise, because in the street there is a lot of noise, and you can have a lot of peace with yourself. So I cannot stress enough the importance of housing for the recovery of the people. The people housed can also have better access to healthcare, because then you can have a doctor visiting you in your house, which is generally not possible, or possible in very bad condition in the streets. You can have nurses that come every day at home for your treatment, for your injection or whatever, which is not possible in the street, because people don't know where you are. Normal services don't accept to go in the streets, and so on. You can also store your medication in your home, and if your medication needs refrigeration, it is possible also, which is not possible in the street. So there are a lot of advantages and real direct advantages to be in the house. It seems evident, but it's maybe we are too much accustomed to homelessness and we think it is normal to live in the street. It's absolutely not normal, and it's very harmful for your health. The second word I wanted you to write is addiction. Addiction, you have to manage it when you have patients with addiction. This is the second biggest problem for access to health and access to healthcare.
Yeah.
You probably most of you will think, okay, we will make harm reduction, which is good, of course, but you should not stay with that only, and you should not. Certainly, we do not, as healthcare workers in the street, we try not to be focused on the addiction. So we speak about addiction, we do harm reduction, but it's not our main point. Our main point is the patient itself. Addiction is a symptom of the fact that the person was neglected in her life, and is still neglecting herself. So we try to focus on her, on the person, on her desires, pleasures, and we try not to be too much focused on the addiction, even if addiction is a very big problem for the person. And the person, for example, who are addicted to drugs, for alcohol it's less problematic, but for drugs it will be very difficult for you to have contact with this person, because they are always looking for money, or they are looking for drugs, or they are under the influence of drugs, and you cannot contact them easily, you cannot find them. So you need to be very patient, and you need a lot of time before you have a link and a sufficient band with the people. And that leads me to another important word, is trust. Two important words. So trust is an enormous facilitator. You need the trust of the people, otherwise you cannot work with them. And they will say yes, yes, superficially, but you will not be able to work really on health or any other topic. And to build up this trust, you need time, and people need time to trust you. You have to accept that. And time, it's not weeks, it's months, generally. And for some type of patients, for example, psychiatric patients, it could be even more than 1 year to have a real trust. So you have to be patient. There is nothing else to do. But if you have...
Just to let you know, 3 more minutes.
Okay, well, I knew it, but it's even worse than I thought. So the other point I wanted to stress was mental health. And mental health, you have to detect, support, and treat if you can, because it can be a big obstacle to compliance. I'm thinking about psychosis, where people are not at all interested by care. And I'm thinking also about depression, where people don't give any signals of problems, and they tell you, oh no, I'm fine, or I don't need anything. So in these two cases, you have to be very proactive and you have to be persistent. And also it's the same, you need time and you need trust to build up the trust. So that's very important. And the last main obstacle is the status of the person. So illegal stay can be an obstacle in some countries. In Belgium, it's not an obstacle for healthcare as such, but it makes healthcare more complicated and time-consuming. It gives no possibilities to rehouse people, which is a big problem. And it's also depressing for the person because she realizes that there is no perspective. So as a conclusion, there are a lot of things to say, but as a conclusion, remember, housing people is the biggest health action that you can have for homeless people. So try to give you the means to rehouse people. So, for example, we have one full-time person looking for housing because it's so important for us. Remember, time is important. So, and we are speaking about at least weeks or certainly months or sometimes even years. People need time to change and they need time to build trust to you. And trust is the main factor for success with these people. And then with the healthcare, when you can install healthcare on a more systematic way, keep it simple, spread ambitions, and keep up to your priorities and take into account the priorities of your patients. That's it. Thank you.
Thank you very much, Pierre, for such an interesting presentation, the focus on the field. Now we can move on to our second presentation with Istvan van Dande from the Budapest Methodological Center of Social Policy and its institutions of Hungary. You can start whenever you want.
Thank you, Raquel. Hello, everyone. Can you hear me?
Yes.
Very good. So, welcome from Budapest, from this very, very long-named institution. This institution was established by the capital city of Budapest, and we are providing services mainly in the area or within the area of the capital. That I'm going to show a brief overview of our services and just to see how they are connecting to each other and how health services operating within these complex institutions. As you can see, we have many origins social services. You can see both the Hungarian names, but I put into brackets to the, well, let's say international name that you can compare what kind of services we provide as a social institution, and you can see they are mainly emergency type of services. Here in Hungary and also in the capital, we basically don't have housing-led approaches, or we have only very few housing first projects. Basically, we have big crowded institutions where we can provide better or less better services for people experiencing homelessness. We also have 3 temporary homes for families and also run 5 workers' hostels. And you can see that we have nearly 4,000 available spaces within our institution. So they are, at least within Hungarian circumstances, it's a huge institution. And we have a dedicated health service within all these services that you can see. We could organize different services from the primary care to the secondary and to the third care of health services. And just to give you a quick overview, we have 2 family doctor services that they are available basically non-stop every day of the year. And what I think that could be a sort of Hungarian specialty, that into these health centers are linked so-called, we call it convalescent or recovery rooms, with altogether 36 beds. If I jump back to what Pia was mentioned, that when they are meeting rough sleepers on the streets and there are high risk to provide medicines or serious treatments, and the original idea for the establishment of these recovery or convalescent rooms was indeed that when the street workers meet rough sleepers on the streets, they were many times in very poor health conditions, but honestly, they weren't sick enough to transport into the hospital, because then the doctor in the hospital would say that there is no acute symptoms. I cannot provide a space, but of course they were sick enough not to place them in a social institutions. So they are somehow between the social and the health service, which provide a safe space for even weeks or even more time until they'll become better. We also have a psychiatric service with 20 hours a week, a dermatology service 9 hours a week. They are incredibly weak hours. We would need much more than these capacities. 2 years ago, we established the so-called trauma conscious gynecological service with a 5 hours capacity, and we have a small hospital even in Budapest with 2 different departments. One of them is an internal medicine department with 53 beds and a nursing department with 20 beds. Both of them are providing chronic services, so we don't have special and modern diagnostic tools and whatever. It's basic chronic health service. You can see that the staff includes at the moment 23 doctors and 55 nurses. And yeah, we are very proud that the gynecological service won the Audience Award of the Social Murray Prize in the last year in Vienna. So I tried to collect all the key challenges that we are facing with at the moment, and just to reflect to the main question of this webinar, that how to overcome the barriers, you can see that we have a very, very simple answer, because we created parallel or a more simple way segregated services. I really don't know if this is the right answer or this is the good way, but we did it and we operate. To be honest, we experienced that it's any of these services that you see in this slide, it's basically not enough. We always facing bigger and more needs that we could reply. And even in the mainstream health services, we experience that many times they do not offer the proper health service to people experiencing homelessness, because they say that, well, you have the family doctor services, you have the dermatology service, you have even a small hospital, then please go there and take that service. We are fighting many times with the mainstream services. The other interesting thing what we experience, and probably it's a general phenomenon which might be also experienced in other countries as well, which is the aging societies in Europe. And we see it as the Hungarian society as a whole is aging. We experience the same in our social institutions. You can see the average of our inhabitants in the social institution is nearly 60 years. 10 years ago, it was less than 40. So basically, the homeless sector in Budapest is towards a hidden transition towards healthcare and into services to old people. What I also touched earlier, that there are somehow situations when the social institutions do not have the proper staff and tools, because of the level of self-care is not sufficient many times, so they cannot provide adequate service to people experiencing homelessness, but they are not sick enough to send them into hospital. So many times we are balancing between the two different type of institutions, and we don't have a systematic answer. Usually in Hungary, you can apply for a space into a home for elderly, but that would require at least a good pension, which is many times, of course, missing in case of our clients and people experiencing homelessness. So we are trying to provide some more health service in our social institutions, but it many times not enough and not sufficient. Yeah, and earlier it wasn't a serious issue, but more or less 2 years ago we experienced that if you don't have a health insurance as a homeless people, then many hospitals will issue an invoice, and officially you should have to pay the health service what you received. And as a result, of course, we experience earlier hospital discharges, and again, these people would come to the social institutions without proper services. So basically, this is the question marks here in Hungary and Budapest. Thank you very much, Raquel.
Thank you, Ishvan, and thank you to all our speakers. We are 6 minutes over time, but that is pretty good to give us enough time to pick up on questions. So once again, please, everyone, write your questions in the chat, or if you want to intervene and take the floor, that is also possible. Just raise your hand. And maybe I will get us started with a question to our speakers already. But before that, I just wanted to pick up on the point about housing, as Pierre described it, but it also came through from the other presentations. Is it a medical factor? Is it a social factor? How do we approach it? And just to say that, of course, we are in FEANTSA working on highlighting that we do have a crisis housing going on in Europe, and we are looking into housing solutions, while at the same time, of course, it's very important to keep an eye on the impact that the lack of housing, of safe shelter, has on people's health. And so with that in mind, maybe the first question that I would like to ask our speakers to reflect on is, because of the common factors that we have seen that are acting as barriers and challenges to people accessing healthcare and health services when they're homeless, and this circle of barriers. How do we break this circle if we think from the perspective of health services? Where do you see an entry point where health services can make a better intervention to support people experiencing homelessness? What would be the point of entry that you would prioritize? If you want to share any thoughts about that.
Well,
sorry.
oh, sorry.
Please go ahead.
Go ahead.
Okay, so thank you for this very important question. I think this is also a question that we have been asking ourselves quite many times. But from our experiences, particularly from the Cancerless project, I think a very important point in time, and this was also one of the outcomes that we derived from one of our other studies that was conducted within Cancerless, is that the point of entry should be already before a disease has developed. So this is again where we are focusing on preventive care. I think this is a very important point, because especially in the preventive stage, we are actually able to do a lot of things. So this is the point where the severity of a certain disease hasn't developed to a stage where it is very difficult to treat it, but where we have actually more possibilities to counteract something. So prevention is very important, because it gives us also the chance to establish, and this has been mentioned now in I think all our presentations, it's something that allows us to actually build this rapport between people experiencing homelessness and healthcare providers. Because of course, always when a certain disease has already developed, then it's always the disease, I think, that is in the focus. And if we already try to build a relationship between healthcare providers and those in need of help before a disease is there, it's much more efficient to take care of the health needs.
Yes, do you want to add on that?
Yeah, I would say as the entry point for me is outreach teams. You have to go towards the people, and then you have to go with the people. That's very important for me, because you need people to translate the medical language for the patient, and the patient's language. I mean, sometimes people do not express themselves very well, and you have to be able to translate to the caregiver. The outreach team is also important as it acts for a long time as a case managing team. So they are the focal point for all the information about the patient, and they will be able to treat it and to see there is an appointment and things like that. Otherwise, it will not work. And don't count on the GPs to do that. They will not do that. It's not their task. So it's the task of the outreach team to do the case managing. You have also to show, the outreach team has to show to the medical structures and professionals that what they will do on medical aspects has a meaning, is meaningful. I mean, if you bring someone to the hospital, you as an outreach team, you must be able to say, when the people go out of the hospital, we will continue the follow-up, we will ensure what it takes, we will come with him to the specialized consultation in the hospital. Otherwise, there is no motivation for the medical staff to do work. That is very important. Once the hospital understands that you are there to follow up and you will be there to complementary to their work, then they will be motivated to work for the patients. Otherwise, they will just say, well, he comes here every 2 weeks or every week, completely drunk, and we will not do anything because it's not useful. And the last point for the outreach team, it's important. Well, it's very useful. Maybe it's not absolutely necessary, but it's very useful to have at least a nurse in the team. So we have always nurses that can go to the hospital, the medical consultation. Someone who has some medical understanding of what's happening and can also discuss with the medical staff and sometimes defend the patients. And then the last point, but it's a little bit weaker, I would say, is more information and training for the medical staff, for example, in emergency services for general practitioners and so on. We give this training in Brussels and also in some other parts of Belgium, and we see that, yeah, it's very important for them to understand the logical of living in homelessness. For example, speak about hygiene. How do you do that? And we train also some social services, mainly about how do you speak about hygiene and these kind of things. But of course, you have training like that. You have to do it over and over again because there's always new stuff and so on. So it's a little bit more difficult.
Thank you. I will come back with a follow-up question to something you mentioned, but first, Istvan, I saw you were nodding at some point when medical services and outreach were mentioned. Do you want to add something about your experience with that, or about the system in Hungary and how you operate?
Yeah,
with
I was shaking my
Yeah.
head because we have definitely the same experience. Yeah. It was a very good word from Pierre, the translation between the clients and the service providers, especially in healthcare. Yeah, I can confirm that doctors, and I would speak in a really neutral way, but they are many times in a weak and narrow channel within their high level of thinking, as there are just kilometers between the service providers and the client. Yeah, the follow-up is, also to confirm, just to give you a very basic example, when there is someone in our convalescent rooms and he or she should receive weekly or 2-weekly treatment, but they are in a wheelchair, we have difficulties how to transport these people to the other part of the city, because in other housing conditions, you call a taxi, you call a special taxi, you can receive some dedicated service, but we are many times without resources to ensure this very important follow-up. Yeah.
Thank you. So the follow-up question I had was something about outreach indeed, because Pierre, you mentioned that you have this system in Infirmière de Rue, but this is something that you do as an organization. And I think maybe Tobias, thinking about the health navigator, you can relate as well with this type of work, even though it's called something else, it's still a mediation and translation work. And we were also discussing within the Cancerless Project about sustainability and how can we ensure that this practice continues to be known and used. And so again, thinking about the health services, how do you see any possibility about incorporating this type of work within, I don't know, hospitals, the GP? Pierre, you already said that is something that they cannot do, but can you think of other possibilities of doing outreach from the service, the health service themselves? Have you seen this happening anywhere?
Personally, I have long time ago visited some hospitals in the United States where they have some services linked to the hospital who are going outside in the streets, and this is to find patients that they are following, which makes sense. And if you can pay that, it's could be interesting to work like that. Now in Brussels and in Belgium in general, we generally work in the other way. We have outreach services who are more and more with the time involved in medical aspects and in link with the hospitals or the GPs, and then they think, well, maybe it would be good to have a nurse or 2 nurses and to medicalize a little bit our social outreach service. Maybe it's a more economic way to work, and maybe it's easier because hospitals have it's a very closed world, and generally they don't look outside. Once the patients go outside, it's like he disappears. So I think it would be very interesting to have hospitals committing themselves to send their personnel outside. But I think practically it's very difficult to obtain. At least in Belgium, I cannot imagine that they would do that. They have already financial problems, so they will concentrate on what they do in their own walls. So I don't know, maybe in other countries it could be more easy, but in Belgium we have to do like that. And for us, it works more or less, but it's true that the contact and the collaboration with the hospitals is still something complicated. That can be complicated, yeah. And it remains a problem. I mean, something to work on, and especially for psychiatric cases, it's not easy. But it is also due to big constraints of the hospitals. So they have to limit the duration of hospitalization. They don't know the context. They don't see where the people live. So sometimes they take wrong decisions, but it's because they don't know the context and because they have financial constraints. So, of course, having a team from the hospital going on site, it's very good. It would be very ideal, but I don't know if it's possible. We have sometimes some nurses from the hospitals going with us or spending 1 or 2 weeks with us to learn how we work, and I think that's also a good experience.
Thank you. Tobias, do you want to reflect on this?
Yeah, thank you. I think it's not only the hospitals, as Pia mentioned, but also, of course, places that are familiar to people experiencing homelessness. So, for example, in Cancerless, we have been collaborating very closely with different organizations that provide practical and health care to vulnerable and neglected communities. And this was a very, very advantageous approach, I would say, because often the people knew those places already. So there wasn't this personal barrier, because they may have experienced some, as we all said, social stigma within hospital care services. And it's not only, I think it should not only be limited also to healthcare services, but also social care services, daycare centers, for example. So people who are just, who may be just there as kind of a very low threshold person that you can just approach when you are interested in what can I do for my own health? Because this is something we also found in the study, that people are very interested in health topics, but they just don't know, just don't have the resources to get specific information. They don't know who they should ask, where they should go to, what kind of services are available to them, and things like that. So those are actually, I would say, minor things that could be changed very easily, but of course it's always a matter of resources, and can you afford a person like being working, for example, as a health navigator in the service, and just providing this kind of support to people.
Thank you. Raquel?
I'm Antonia Jacobi. She asks, thanks for the interesting talk. I was wondering, what is your experience in terms of intersectionality? Do you have specific approaches, tools, methodologies to better accommodate different intersectionalities in practice? She asks generally.
I mean, here again, I can also again mention the health navigator model, because it's a very, as I said, a very individualized approach, very tailored approach. So health navigators are working with individual clients, with people experiencing homelessness in this case, and they do get a lot of information from them on what are their needs and what are their resources, how can they assist them, or what are their preferences in terms of healthcare and social care. So I think it's a very, in terms of intersectionalities, it's very important to have a very individualized approach that looks at each person in particular, and is not just a general, very general approach that does not take into consideration specific characteristics of users. Yeah, I don't know if the colleagues from the practical fields do want to add something on that.
I'm not completely sure I understood the question very well. What do you mean by intersectionality?
Well, so what I'm thinking about is obviously there is like first of all, thank you for answering. There's like the intersection between health and homelessness, right? So like it impacts one another. But then there's also other categories like gender, like disability, like I don't know, race, all these different categories that also play along. So how does it impact your working experiences, and what do you do to accommodate depending on the different situations?
Okay.
Is it clear now?
Yeah, thank you. Yeah, we have, of course, you have, for example, an African migrant. He's in the streets since 10 years. He has a psychosis. He has trauma, and you have to cope with all of that. And then, yeah, it takes time before you know exactly maybe his story, and also, but it takes time. But it also takes your energy not to go too proactively and intrusively in his story, but to let him the time to tell you what he wants to tell you, and what he likes and what he is able to do, because you have to look at things that are possibly problematic, but also and certainly with the same importance, you have to look at the aspects of the person that will help you and help the person to go to a more normal situation. So, for example, does a person has kids of children somewhere, family? What did she do before being homeless? She had a job. She had some great experience. What can she still do? I mean, that can be everything, drawing or not only what she has done as a profession, as a job, but also other things. What does she like? What would she like to do? Dreams and so on. So all these aspects, certainly, as Tobias said, we should consider the person as a person and not as a case. I mean, and not as a problem. And the person herself should think of herself as, okay, I have a lot of resources also, and focus the person, trying to bring also an attention of the person on what the resources she has, the good remembrance she had from the old time. It's also a positive thing. So, and of course, then you have to, especially when you go with the person to certain, for example, administration or even healthcare, in some cases, you have to be present to avoid or to diminish stigma. There is also stigma for example, psychiatric diseases. So you have to be there to reassure the person. Maybe if there was a meeting who was not positive, to be able to to debrief after that with the person. So, I mean, yeah, it's knowing the person personally and leaving the person give you what she is, and then going with her through all the process and living with her all the obstacles and sometimes the good meetings, but also the bad meetings.
Thank you, Pierre and Tobias. Istvan, do you want to add anything on this question, maybe about your work with women or the elderly that you mentioned in the presentation?
Well, it's a very interesting question. If we would have more 1.5 hours, then I would go into more deep. My experience is that, well, to be honest, if there is a person in Budapest, he's suffering from different psychiatric diseases, then he or she can receive some kind of treatment. If you are people experiencing homelessness with psychiatric diseases, then the stigma will overdrive your health situation, which means that if there is an operation, there is a doctor in a hospital, and there are 3 different patients on the waiting list. If she knows that 1 people among the 3rd is a people experiencing homelessness, then he will take it as a kind of risks because of prejudice, because of previous negative experiences, because of the lack of follow-ups, because of they are not follow the treatment rules and so on and so on, because of specific reasons, but the doctor doesn't care about what were these reasons, very strongly linked otherwise to housing conditions, or more precisely, the lack of housing conditions. So what we see that a doctor many times have to decide how to utilize, how to use resources. And many times they think it's not necessarily a conscious process, but many times they decide that the homelessness is a risk. So people experiencing homelessness will go back and back on the waiting list. Yeah, that's thank you.
Thank you so much for highlighting that. We have reached the time we had allocated for today. Unless there is any last remark that any one of the speakers would like to add, we are going to bring the meeting to an end. And also, once again, just wanted to say huge thanks for your presentations, for joining us today. It is very reassuring to see so much involvement and dedication to health inequalities, both from more research academic level, but also on the ground, especially. We will continue, as I said in the introduction, with 2 more webinars, one focusing on mental health and one on tuberculosis in connection to homelessness. Raquel has put the links in the chat for those of you who want to register. And yes, I see someone says that it was insightful and depressive at the same time. That is the line of business that we are in, but very glad to see that so many people are, they continue with the good work. So thank you very much again for joining us today, and especially to our speakers. And hope to see you next month in the webinar again.
Thank you very much.
Thank you, Simona.
Thank you all. Have a nice day.
Thank you.
Have a nice day, everyone. Goodbye.
Bye.
Goodbye.
Bye-bye.